Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhilas. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on a journey to a 250. In this video, we will be also focusing a significant amount of time in the theory part of the hypogonadism. So, which of the following is the most likely underlying mechanism responsible for this patient's condition? A 16-year-old boy is brought to the office for a well-child visit. The parents report that his teacher has expressed concern about the patient's reading and writing skills. Height is at the 90th percentile and weight is at the 75th percentile. Vital signs are normal, and on examination, heart and lung sounds are also normal. He has bilateral gynecomastia and tanner stage 1 genitalia. Which of the following is the most likely underlying mechanism responsible for this patient's condition? FBN1 gene mutation in chromosome 15, loss of paternally derived genes in chromosome number 15, meiotic non-disjunction of chromosome X, meiotic non-disjunction of chromosome Y, or trinucleotide repair expansion of chromosome X. So talking about Klinefelter syndrome, the patient will be having learning difficulties. The patient will be having sparse facial body hair. The patient will be also having sparse body hair in the genitalia. Gynecomastia will be there. There will be small form testes which will be leading to infertility. The person will be also having long legs in Klinefelter syndrome, and the abnormality is XXY. So you need to remember this form XXY. So this is the one syndrome which is having a longer name rather than the Turner syndrome, Down syndrome. Okay, so these are the most common syndromes that you will be asked upon. So the Klinefelter is a longer name, so it is having a mnemonic. So you can remember this by a longer name, a longer chromosomal disorder. So XXY is there. So this patient with learning disabilities, tall stature, small testes, and gynecomastia most likely has Klinefelter syndrome, the most common cause of primary hypogonadism in male patients. The pathogenesis usually involves meiotic non-disjunction, in which improper separation of homologous chromosomes results in gametes with an abnormal chromosome number. Patients with Klinefelter syndrome have non-disjunction of the chromosome of the X chromosome, typically resulting in a 47XXY karyotype. Klinefelter syndrome is often diagnosed during puberty when the following characteristic findings develop. So there will be primary hypogonadism, which means low testosterone, and high gonadotropin. So primary hypogonadism means that the defect is in the primary organ, the defect is in the primary gonads. Okay, so the defect is in the testes, that there will be small testes. So that's why there is a low testosterone, and there is a due to the lack of negative feedback, that is high gonadotropins. Hypogonadism occurs due to primary testicular failure, hyalinization and fibrosis of the seminiferous tubule. So that's why we have a small and hard testis. So this results in small form testis and agiospermia, which will lead to infertility. Leydig cell dysfunction also occurs and leads to testosterone deficiency, causing sparse or absent facial and body hair, decreased muscle mass, and gynecomastia. The tallest threshold is because estrogen, which is derived from testosterone, is responsible for growth plate closure. The tallest threshold is likely in part due to the low testosterone levels in Klinefelter syndrome. The patients also have an additional S-HOX gene, which likely contributes to tall stature because it is found in chromosome X and Y and is essential for linear growth. Since the patient has an extra X chromosome, the patient will be having increase in the height of their lower limbs, especially. So talking about the hypothalamic pituitary testicular axis, so we have discussed this in our first video also. So there is the hypothalamus which secretes the GnRS, and again there is the pituitary which secretes the LH and FSH. It acts on the testes, and the testes through the Leydig cells, it makes up the testosterone. Now this testosterone either gets converted through aromatase to estradiol or through 5-alpha reductase to dihydrotestosterone. So the luteinizing hormone stimulates the Leydig cells to produce testosterone, and follicle-stimulating hormone stimulates the Sertoli cells to support this spermatogenesis. So FSH has S in its name, so it stimulates the Sertoli cell, which starts with S, and LH is It stimulates the Leydig cells, so L for L. That's how you remember which hormone stimulates which cells. And trust me, this concept about which hormone stimulates which cells is very commonly asked in the examination. So hypothalamus produces GnRH, which goes to the pituitary and produces luteinizing hormone, which goes to the Leydig cells in testes and produces testosterone, which can which by aromatization can form estrogen. Also, this testosterone will have negative impact or negative feedback upon the hypothalamus and the GnRH releasing hormone production. Also, the pituitary produces follicle-stimulating hormone, which goes to Sertoli cells in the testes, and it produces and it stimulates or it facilitates the spermatogenesis and makes the sperm cell. So the testosterone is converted to dihydrotestosterone in the tissues, which is more active. Testosterone is also converted to estradiol in adipose tissue by aromatase enzyme. Actions: male sexual differentiation, maintains male secondary sexual characteristics, regulation of GnRH secretion, spermatogenesis, normal male sexual function and behavior, and maintenance of bone mineral density. So talking about male hypogonadism, so there can be a variety of manifestation. The patient can be presented by failure of puberty. The person can be presented with infertility, male menopause or andropause, or with erectile dysfunction. So it can be either primary hypogonadism or secondary hypogonadism. So male hypogonadism with effects before and after puberty. So if the male hypogonadism occurs before puberty, then the testis volume is generally less than 5 ml. The penis size is less, that is less than 5 centimeter. The patient will be having a high-pitched female-like voice, unicoid stature, gynecomastia, central fat distribution, decreased body and facial hair, and delayed bone age. After puberty, the testis volume is less than 145 ml. There is normal penis length. The voice is broken. There is normal body proportion. There's gynecomastia, and the person will be having normal hair distribution but poor growth, and there is osteoporosis. So talking about secondary hypogonadism, so it is generally due to cause which is above the testis. We can say hypothalamic or pituitary cause, and often presents as delayed puberty or infertility. It can be due to some genetic, structural, or environmental causes. So one important topic that is very commonly asked is the Kallmann syndrome, because it has association with both the uh, reproductive system and the neurological system. So the failure of GnRH secretion and neuronal development and associated with anosmia. So whenever the question will give you a hint about anosmia and there is some mention about the reproductive findings, then you must think about the Kallmann syndrome. So investigation, if there is low or undetectable testosterone, LH, and FSH, the other pituitary function is normal. So only the GnRH secreting neurons have failed to migrate. So that's why there is anosmia and there is decreased GnRH secretion, or you can say absolute stoppage of the GnRH secretion. So there is a low or either undetectable testosterone, LH, and FSH level. So there is normal hypothalamus or pituitary on the MRI, but there will be absent olfactory bulb. So that's what due to the absence of olfactory bulb, the patient will be having anosmia, right? So the treatment is exogenous such as testosterone replacement and gonadotropins if fertility is required. So talking about the idiopathic hypogonadotropic hypogonadism. So it is acquired or genetic. In acquired cases, the men may have gone through normal puberty and later the patient had hypogonadotropic hypogonadism. It presents with low libido, erectile dysfunction, or infertility. Acquired cases may go into remission after testosterone or gonadotropin therapy. So there are some of the miscellaneous causes of secondary hypogonadism. It may be due to stress, systemic illness, the structural defects like anterior pituitary tumor, the drugs like anabolic steroids and cocaine, hemochromatosis, Cushing syndrome, Prader-Willi syndrome, or you can say obesity, hypogonadism and mental retardation is generally present in these sort of patients. So the primary hypogonadism, so it is generally due to some genetic effects like Klinefelter syndrome, double X males, Noonan syndrome, 46XY. So the acquired cause may be due to trauma or orchitis in case of mom's patient, cryptorchidism, the post chemotherapy patient, chronic illness, or drugs like opioids, alcohol, sulfasalazine, colchicine, and cocaine. So how to assess testosterone? So this is also a very good concept that is present there in your different question banks. So you assess testosterone by a diurnal. Since testosterone is having a diurnal variation, you need to measure testosterone on two occasions. So you need to measure 9 a.m. testosterone on two occasions. Commercially available assays inaccurate at lower end of range. The testosterone reduced in chronic renal disease, cardiac, respiratory, and hepatic disease, and also is reduced in obesity. Also, it is also reduced in thiazide, opiates, psychotropic medications, and amiodarone. So you need to exclude these causes before telling that the patient is having testosterone due to the gonadal cause. You also need to measure free testosterone, luteinizing hormone, and FSH. So here we have one question. 17-year-old phenotypic female presents to the clinic for an evaluation of primary amenorrhea. She has never experienced menarche and reports a lack of breast development. Physical examination reveals a tall stature, scant pubic and axillary hair, and a female appearing external genitalia. Pelvic ultrasound shows the absence of uterus and ovaries, and hormonal analysis reveals elevated testosterone levels with normal levels of LH and FSH. Karyotype analysis demonstrates a 46XY genotype. Which of the following best describes the underlying pathophysiology of this patient's condition? So option A, B, C, D, E. So this patient's presentation is consistent with androgen insensitivity syndrome, a genetic condition characterized by a 46XY karyotype in individuals with a female phenotype. So AIS is caused by mutations in the androgen receptor gene located on the X chromosome. So the correct answer is B, which is abnormal androgen receptor function. So this is the correct answer. So AIS is caused by mutations in the androgen receptor gene leading to impaired responsiveness to androgens. So the defect in androgen receptor as resulting in female appearing genetic male. So the patient will be having XY as gene genetic makeup, but the patient will be female appearing, but the patient is genetically male. The female external genitalia with scant axillary and pubic hair, rudimentary vagina, uterus, and fallopian tubes absent due to the persistence of anti-Mullerian hormone from the testes. The patients develop normal functioning testes, often found in the labia majora, which is surgically removed to prevent malignancy. There is increased testosterone, estrogen, luteinizing hormone, versus in sex chromosome disorder, which is decreased. And this is the basic flow chart, the summary of hypogonadism. You can just pause the video and go through it. Thank you for watching. Keep studying hard.